And I'm going to talk about acute myocardial infarction in this video. So regarding acute myocardial infarction, we know that coronary artery disease can be divided into acute coronary syndrome and stable angina, and acute coronary syndrome can be divided into myocardial infarction and unstable angina. Again, myocardial infarction is ST elevation and non-ST elevation. When there are some ECG changes and elevation, there is ST elevation in ECG in myocardial infarction, we call it ST elevation MI. And if there is no ST elevation, there is no proper ST elevation, then we say if it is a MI and troponin is raised, then we call it non-ST elevation MI. So the myocardial infarction is basically irreversible death of heart tissue, where heart pain or chest pain is called angina. If there is a partial infarct, then it can cause non-ST elevation MI, and usually the ST elevation MI is caused by a transmural or whole wall thickness infarction. How are we going to differentiate a stable angina and unstable angina? Usually the stable angina is relieved by rest or medications like GTN spray, and unstable angina usually does not respond to rest or medications. The features of myocardial infarction or acute myocardial infarction is usually it presents as a chest pain, which is a central chest pain, can be crushing central chest pain, which radiates to left arm, radiates to jaw, and can radiate to neck as well. And usually it can be associated with things like excessive sweating, nausea, vomiting, shortness of breath, maybe weakness and palpitations. If there are symptoms of heart failure, then it can present with shortness of breath. And in some cases, like if a patient is diabetic, then it can be there may be no symptom. In that case, we would call it silent myocardial infarction. There is some atypical presentation as well. Sometimes myocardial infarction can present as with a abdominal discomfort or just the jaw pain, or in an elderly patient maybe just altered mental state. We are going to talk about investigations now. The best initial test of a patient who comes with a chest pain, and if we suspect that the chest pain has a pain, and if we think like it's a cardiac chest pain, then we will go for the best initial test is an ECG. And in case of myocardial infarction, troponin is a very, very important test. By troponin, we can differentiate that if the chest pain is a unstable angina or if it's an MI. Usually troponin is raised after 3 hours of chest pain, and it peaks around 24 hours, at around 24 hours time. Another very important enzyme, which is called CKMB, it is also raised in myocardial infarction. And other tests we can do in myocardial infarction is like echocardiogram, and routine bloods is always advisable. What can be the ECG features of a patient with myocardial infarction? Of a patient with ST elevation MI. Usually, if there is a ST elevation is in more than 2 millimeter in two contiguous chest leads, like in V1 to V6, or if there is just a ST elevation in two contiguous limb leads, if it's more than 1 millimeter, more than equal 1 millimeter, or if there is a elevation in AVR, which is more than equal 1 millimeter with widespread ST depression, then we also can call it an ST elevation MI. Sometimes maybe a new bundle branch block, which is a left-sided block, or maybe ST depression which is more than equal 0.5 millimeter in V1 to V3, and dominant R wave in V1 or ST elevation more than equal 0.5 millimeter in leads of V7 to 9. Next is, how are we going to manage a patient who we suspect that if it's an myocardial infarction or acute coronary syndrome. Initially, we have to think about like what is the renal function of the patient, how much is the EGFR. If EGFR is more than 30, then usually aspirin and clopidogrel, they are safe in renal impairment of patient. But if there is significant renal impairment, it's ideal to see renal drug and prescribe. The second thing is that is the patient already on any anticoagulant? So if the patient is not on any anticoagulant, then the first line treatment is aspirin 300 mg stat and ticagrelor 180 mg stat, and followed by fondapinax, which is a low molecular heparin. And it's ideal to not to prescribe VTE prophylaxis if patient is on fondapinax. The second thing is that if the patient is already on anticoagulant, then we have to think about why patient is taking anticoagulant. If patient is taking anticoagulant because of atrial arrhythmia or DVT or PE, and if it is a newer drugs like DOAC or warfarin is not new drug, I'm talking about DOAC. Anyway, so if the patient is on warfarin or DOAC, then we need to prescribe aspirin, clopidogrel, and regarding low molecular heparin, we have to hold DOAC and prescribe enoxaparin. If patient is on warfarin, we will hold warfarin and should prescribe enoxaparin. And along with those medications, it's ideal to prescribe lansoprazole, which can be 15 to 30 milligram daily. Now, if the patient is on warfarin because of mechanical heart valves, then again we need to continue the warfarin, and better to contact cardiology as soon as possible. All right, and basically this video is for candidates who are going to take UKMLA part 1, or you can say PLAB part 1. So I'm not going to discuss a lot about those things. I'm trying to be quick so that every candidate can finish the video as quickly as possible. What are the other medications we need to prescribe in a patient who who are on ACS protocol, or who has acute myocardial infarction or unstable angina? So other medications are like morphine. If patient's renal function is not impaired, then morphine is the analgesic of choice, along with plus minus GTN spray. And bisoprolol 2.5 milligram daily if patient is not elderly. And aim is heart rate, keeping heart rate around 60. It's better to see the local hospital protocol as well. So the function of bisoprolol here is the decreased oxygen demand of heart. Other thing is the cholesterol lowering medications like atorvastatin 80 milligram at night. And if patient is on continuous pain, then we can consider GTN, intravenous infusion. Again, better to contact with cardiology before that. If patient is on if patient's blood glucose level is higher, like more than 11 millimolar per liter, then we can start a variable rate of insulin infusion because of that. So these are all from my side for acute coronary syndrome today. Let me know, guys, if you liked it or not, and if you have any question, make sure you comment and I'll be there. Thank you for watching the video. Thank you so much.